Hi, welcome to the CRCR Bootcamp put on by the Arizona HFMA chapter. My name is Tori Wasson, and I'm currently a Patient Access Director at Banner Health. I have been in the industry for about 21 years, serving in various roles, as primarily working with the outpatient imaging centers. I also currently serve as the secretary on the AZ HFMA board. Looking forward to spending a little time with you today. I will be covering units 1.1 through 1.5. The material that we are going to go over today is meant to be a supplement to the study materials and practices and all of the quizzes that are available online. We really want to make sure you're not using this boot camp to replace those study materials and just using it as an additional tool for studying. So with that being said, we'll go ahead and get started. Units 1.1 through 1.5 cover the patient-centric revenue cycle, and we will be going in more detail on each one of these sections. The objectives for these sections are: number one is the patient-centric revenue cycle overview, then healthcare dollars and cents, patient experience and satisfaction, collaboration and continuum of care, and then compliance and HIPAA regulations. So let's go ahead and get started with section 1.1. This is where we're going to learn more about our revenue cycle overview and those activities that occur during a revenue cycle. This graphic is the full visual of our revenue cycle, starting with that consumer experience, then patient experience and customer experience. It includes all the major processing steps required to process the patient account, from their request of service all the way through the zero balance of that account. So I know this graphic can be a little busy. We are going to review each section at a time so that you can learn more in further detail. All right, so our first section is engaging the consumer. Healthcare has changed and evolved over the years, and patients are really now consumers of healthcare. We are looking at our first segment of the revenue cycle, and during this process, we want to engage the consumer, and that is done through all of our pre-services processes that you see here on the page. Scheduling and pre-access set the stage for effective communication with the patients and data collection. It's critical that the providers optimize these steps to avoid the downstream impacts such as denials, increased cost to collect, increased bad debt, and then dissatisfied patients due to surprise bills. During this process, the encounter record is generated and the patient and guarantor information is obtained and are updated as required. And then we also want to make sure that during this section, we are screening for medical necessity, looking at the health care plan coverage and benefits, and verifying all of our pre-authorizations have been completed. We also want to create estimates to inform the patient in advance of their service, their cost, and whether they're going to have a deductible, coinsurance, and or copayment amount to be responsible for. This should all be done prior to service to help the patient make those informed decisions as a consumer and not be surprised by any bills. And also we should start having those financial conversations and providing that assistance information during this step as well. All right, so moving forward, we're going to go into our engaging the patient section. This next process of the revenue cycle is the patient experience at the time of service. Ideally, this patient has already been scheduled and pre-registered and can go directly to the service unit versus waiting in the main registration area. During this time, they sign all of their consents, and if not collected during pre-service, agreed upon payments are made. Positive patient identification is completed and the patient is given an armband if applicable. And then unscheduled patients or non-pre-registered patients will have to go through the comprehensive registration process at this stage. And then finally, in our last section of our revenue cycle, we are engaging our customer through all of our post-service functions. Post-service includes the account activities that occur after the patient is discharged until that account reaches a zero balance. So during this stage, we have all of our final coding of all the services that were provided, preparation and submission of claims, payment processing, balance billing, and then the resolution to that zero balance. This process is really dependent on the actions that occurred during the pre-service and time of service. So it's very important that providers invest in optimizing their processes and embracing the technology to try to avoid all of that rework and increase of the cost to collect on the back end. We also want to ensure that on the back end, patients want healthcare conversations and communications that are personable to them. So we need to treat each patient according to their needs, using technology and digital options as appropriate too. And that is our final section in our revenue cycle. So let's go ahead and review some of these key points that we went over. So just remember, we have 3 segments of the revenue cycle. We have pre-service, time of service, and post-service. During pre-service, we do all of our scheduling and pre-access processing. And then during time of service, we do that final account review, financial processing, and anything that needs to be done for our unscheduled patients. Lastly, all of our account activities that occur after discharge in the post-service section happen there, all the way through that zero balance at the end. So first, we're going to go ahead and do a practice question to start getting us practice on this exam. On this one, our question is, what happens during the post-service stage? So we have several options here, and when we review each one of these, the one that best fits this question is this one, which is during post-service, we have our final coding of all of our services, preparation of claims, payment processing, and balance bill through that resolution. So that would be the best answer for this question. And you will see that highlighted there. Okay, so we're going to go ahead and move on to 1.2, which is our healthcare dollars and cents section. Now more than ever, patients are asking about the price of healthcare. They are called on to make more decisions, pay more out-of-pocket costs for the services they receive. And this is where, again, we talked about them turning into consumers. So in this section, we are going to look over options for patients and what HFMA has in their toolkit to help providers with this. These patients are looking for more information because they really want to find and pay for quality care. Healthcare Dollars and Cents aims to answer these questions and to really help make sense of price and value in healthcare. So what we're going to review is these voluntary practices address the area where best practices are most urgently needed, really focusing on the financial discussions that take place in advance of healthcare, at the time of service, in the ED, and in other care settings. They provide definitive guidance about when and where patient financial discussions should take place, who should participate, and what those topics should be. First and foremost, we need to respect the patient's privacy. Of course, also in the ED, no discussion should occur before a patient is screened and stabilized. We will learn more about EMTALA later in this boot camp to ensure that we are having those conversations following the EMTALA processes. The patient-provider conversation should consist of the following: compassion, communication, written follow-up, and then compliance frameworks and HFMA's adopter program. All right, so price transparency. This has been a hot topic for a bit of time now. Providers have had these mandates from CMS to provide the charges in a machine-readable format with shoppable services as well. The need for transparent healthcare pricing has never been more important due to the need to help these consumers make smart and educated decisions about the care that they receive. So in order to provide our patients or our consumers with the information that is meaningful to them, several factors must be included. First, we want to include the type of service based on the CPT or MSDRG code, the total charges, the contracts or fee schedules per health plan, and real-time patient eligibility of the patient's current out-of-pocket amount. Recognizing the industry's need for guidance concerning this topic, HFMA convened a task force to help develop 2 documents. The first one is the Price Transparency Report, and the second is the Consumer Guide to Healthcare Prices. Both documents can be found in the resources section of this course. HFMA also created the Medical Debt Task Force that builds off HFMA's patient-friendly billing work. Best practices here include educate, communication must be clear, concise, correct, and patient-friendly, establish policies and make sure they were followed internally, be consistent, coordinate to avoid duplicative contacts, exercise good judgment, timing, start the clock when that first statement is sent, and then report and track. So both credit bureaus, if needed, and track all consumer complaints during this. We've come to the end of this section. So the key points to remember are that the healthcare dollar and cents name is given to the 3 HFMA revenue cycle initiatives. We have patient financial communications, price transparency, and medical account resolution. And then we want to also ensure that our communication and sharing information with patients really helps support that high level of patient satisfaction. A little later on in this sections, we are going to talk about the impact of our patient dissatisfaction, so that it's definitely an important piece here. And our question for this is, which option is not a main HFMA healthcare dollars and cents revenue cycle initiative? And before I share the answer, I want to point something out that is helpful for when you take the test. When you are reading these questions, please make sure that you're paying attention to the not, or what that keyword is. So in this question, it is asking which option is not a main HFMA healthcare dollars and cents. So you can start to eliminate some of the answers by remembering which ones are, and then come to the conclusion of which is not. So in this one, our answer is process compliance. That was not one of the healthcare dollars and cents as a part of their revenue cycle initiative. Okay, section 1.3 is our patient experience and satisfaction. Patients expect value for their healthcare dollar, including greater transparency of quality and price information, similar to what we've been talking about on our previous slides. So we're going to go into this in more detail. Patient satisfaction also means that patients must understand the provider's payment expectations and terms. And even better if we can get all of those up front prior to them coming into their appointment. So today, with our patients being consumers, we do have a patient satisfaction metric. The HCAHPS is the Hospital Consumer Assessment of Healthcare Providers and Systems Initiative. The objective of this initiative is to provide a standardized method for evaluating patients' perspective on hospital care. For additional information on this specific survey, it can be found at the cms.gov, and you can search for quality initiatives. Of the 27 questions that are on this survey, only one question encompasses the entire patient experience, and that is, would you recommend this hospital to your family or friends? So if they say yes, that shows you what their experience was, which is a positive one because they are going to recommend it. If it's no, then that can impact those hard and soft costs of losing patients and then their friends and family based on their recommendations. Revenue cycle team members play a huge, very important role in the patient satisfaction, even if these team members don't have direct contact with the patient. The revenue cycle, it's important to implement processes that are patient-centric and efficient, and that during this section that we ensure that we educate the patients about their insurance coverage and their potential out-of-pocket costs. And then we also want to communicate financial information clearly, consistently, and timely. This is so important. Most patients do not understand their benefits, or they don't understand what their out-of-pocket, what deductible means, co-insurance, copay, and all of that. So it's so important that when we're having these conversations that we're explaining all of this, and that's really going to help with that patient satisfaction and them really understanding what they're going into when they're having their service done. And now we get to our costs of our poor quality patient experiences. So these can definitely cost the facility. Our hard cost is going to be the loss of revenue, and the soft cost is when the patients share their poor experience with others, which end up turning into hard costs of loss of volumes and revenue. Great clinical care can be eroded based on both the experience in the front end and back end collection efforts. So the clinical experience may be great, and then on our processes on the front end or back end and the revenue cycle, those can impact the patient experience, even if the clinical one was a good one. To improve our quality and decrease our back end billing, we want to make sure we're doing all of our insurance verification, our pre-auth, pre-cert, and all of those prior to the service, and that will really help decrease some of that cost of the quality of poor experiences on the back end. And as we come to the close of this section, we'll just review a couple of key points. It's important to implement extensive training for staff to ensure they understand the importance of the patient experience and customer service. They have a responsibility to efficiently and professionally gather all the information necessary to support the patient intake process. It is also important to recognize that there is a significant organization cost if policies pertaining to communication, customer service, and quality assurance processes are not established. And worst case scenario, legal issues can also arise. Okay, so let's move on to our question. What is the objective of the HCAHPS initiative? So again, we talked about this one in the beginning of the section. This is a survey to provide a standardized method for evaluating patients' perspective on their hospital care. So our answer would be that first one. Now, again, we come to another not question. So which item is not best practice? And the answer on this one is right here. Report to healthcare plans when a patient account is transferred to a collection agency. So in this case, there would be no reason why we would need to notify a patient's health plan that they were transferred to a collection agency. And rule of elimination, if you weren't sure about that, the others, if you read them, are best practice. Okay, and moving on to 1.4, collaboration and continuum of care. In this section, we're going to discuss a couple departments and personnel with whom the revenue cycle staff and leaders will work with in a patient-centric revenue cycle. Healthcare providers today are faced with an increasingly complex operating environment. Using and optimizing technology provides a competitive edge and decreased costs. We know these days automation and AI is both one of those words that is thrown around all the time now, and all of our healthcare facilities should be working closely with their IT teams to see where they can implement some of that automation and AI to really help. And in doing this, we can streamline operations, increase productivity, access profitability by health plan and patient type, and provide that quality care. So this is a very important partnership that you can have within your healthcare facility. Next, let's talk a little bit about the continuum of care. So this is a way of coordinating and linking healthcare resources, facilitating a seamless movement among care settings. So it seeks to implement linkages to connect patients who are leaving the acute care facilities and services. The coordination of care has gained importance as alternative payment models expand to include bundled payments. Physician offices provide the orders, schedule the service, and obtain the authorization. And some of these examples of these providers include physicians, skilled nursing facilities, hospice, assisted living, several different coordination of care providers that the acute team will work with. This section was one of our shorter ones, but we do have a few things to review in our key points. Common software applications include but are not limited to scheduling, ADT systems, EMR, electric claim generation, to name a few. Many facilities also have other systems integrated within their EMRs to provide eligibility verification, estimation generation and automation, and other processes for analytics. So they're having those bolt-on or other systems that work with their EMRs to provide that information. Patients, in addition, want those more digital options to schedule and pay their bills or use a chat function for questions without having to call into a live person. So again, it's extremely important that we're looking at all this technology and in the revenue cycle partnering with our IT team. In addition, we collaborate with clinical services, and we also collaborate with finance. When finance is usually responsible for the compliance with state and federal reimbursement reporting requirements, but they also can provide modeling for contract negotiations and estimates of the impact of regulatory changes on the provider's financial performance. And then for our continuum of care, just a reminder, this is a way of how we coordinate and link the healthcare resources to really avoid that duplication and help make that patient experience seamless among all the care settings that they may experience along their healthcare journey. And the overall goal is to just work together in coordinating that patient's healthcare and ensuring that they have a good and seamless experience there. Okay, so which is not a department that supports and collaborates with the revenue cycle? And when we look at these 3 or 4 different options, assisted living is the correct answer, because again, Assisted living is a non-acute care residential facility. So it is a provider that would be a part of that continuum in care, but it's not a department that the revenue cycle collaborates with and supports. Okay, and then here, which option is not a continuum of care provider? And in this example, our correct answer would be health plan contracting. So this one reviews contracts for accuracy. It is not one of our providers that is in that continuum of care. And you will see that highlighted there. Okay, we are going to review the last section with me, and then I will be turning it over to one of my colleagues. In this section, we are going to talk about the essential elements of a compliance program in HIPAA. We're also going to look at the purpose of the OIG work plan. The Office of Inspector General developed the Model Compliance Plan for labs in 1997 and for hospitals in 1998, followed by a dozen other guidance documents for pretty much every healthcare provider and service, just like DME and pharmacy. They cover the key risk areas that are perceived to lead to potential fraud and abuse. And next, we're going to be talking about some of these risk areas and ensuring we have processes in place to mitigate these. All right, first, the compliance program. This really is a comprehensive plan along the lines suggested by the OIG, indicates that an organization is serious about being compliant with regulations and may serve to keep the federal government from dictating a plan for it. So you want to get ahead of it and make sure that you have all of these things in place so that the federal government isn't dictating that plan for you. It'll also insulate the hospital from violations of false claims and fraud and abuse regulations. And here's some examples of things that we want to make sure that we have policies and procedures in place to avoid. All right, so these are the essential elements of a compliance program. And we want to ensure that we are tying the organization's program and policies together and providing copies of the policies and procedures and reviewing. It's important that we have that regular training, hotlines to receive anonymous communications, and then from there, having structure in place to ensure that we're monitoring and then communicating any changes with our teams. We also want to ensure that we have self-reporting available. And really the purpose of the compliance program is to create a program that is transparent, clearly articulated, and emphasized at all employee levels. And that is huge. You want to ensure that it is important no matter what part of the system you are or what role you are in, you are aware of all of the compliance program. You are going through training. And then also that the compliance program really does rely on full communication inside and outside of the organization. All right, so our question here, which of the following are not essential elements of a compliance program? And in this one, we actually have two correct answers. So you on this question would have the opportunity to pick more than one answer. And the two correct answers are automatic dismissal of any employee excluded from participation in the federal healthcare program. And then lastly, designation of a compliance officer employed within the billing department. So we would not want the compliance officer to be employed within the billing department, and we'll talk a little bit later about why. So there's that first answer and that second correct answer. And now we're going to talk about the code of conduct. This is really believed to be the backbone of the organization's compliance program. The code of conduct, if implemented effectively and enhanced as needed, can reduce weaknesses by helping employees and agents understand their particular roles and responsibilities, while fostering an environment where concerns and questions are raised without fear of retaliation or retribution. So you really want to emphasize that and not have team members be scared to come forward to report things, because that's how you know, and that's how you're going to be able to fix it. It really is a living, breathing embodiment of the program. In the most effective programs, the Chief Compliance Officer reports directly to the board of directors or trustees so that they can maintain that independence. So again, we don't want them reporting to a department like billing or anything like that. Now let's talk about the Office of Inspector General, or the OIG. This was created to protect the integrity of HHS. Really, the role here was to identify and hold accountable those who do not meet program requirements, publish an annual statement of work, but now is updated as needed on a monthly basis, and then also create work plans to include initiatives. Some examples of these initiatives were the prescription opioid drug abuse, Medicare payments made outside of hospice when hospice is being paid for these services, and denials and appeals in Medicare Part D and Medicare Part C. And now we're going to talk a little bit about HIPAA. And I'm sure as healthcare providers, you are all familiar with HIPAA, but the goals of HIPAA are really protection of patient information, restrictions of access to PHI, and ensuring we have our business associate agreements, or BAAs, in place. Part of HIPAA, there was a rule to standardize the electronic formats so that our data is all being transmitted using one standard electronic format across the board, and we don't have a bunch of different types of transaction sets. So we're going to go over some examples of these that you may have heard of. The final rule adopted standards for 8 electronic transaction and code sets that are to be used throughout the healthcare industry. So some examples would include our eligibility benefits are a 270 and 271. We have our claims, which are 837, and so on. These are just some examples of those 8 transaction code sets. Another standardization is the use of a unique employer identifier, and this is also required under HIPAA. The rule adopts the employer identification number assigned by the IRS to be used in standard transactions to identify the employer of an individual described in the transaction, such as the transmission of enrollment or disenrollment information to a health plan. Any business required to furnish a taxpayer identification number must use an employee ID number, or an EIN, as its taxpayer identifying number. And then lastly, another HIPAA identifier standardized is the National Provider Identifier, or the NPI. And the NPI is a unique identification number for covered healthcare providers. Covered healthcare providers in all health plans and healthcare clearinghouses will use the NPIs in the administrative and financial transactions adopted under HIPAA. The NPI is a 10-position intelligence-free numeric identifier. Essentially, it's a 10-digit number. This means that the numbers do not carry other information about the healthcare providers, such as the state which they live in or their medical specialty. Also, beginning May 23rd of 2007, The NPI must be used in lieu of legacy provider identifiers in the HIPAA standard transactions. Okay, so let's talk a little bit about privacy of healthcare information and best practices in our organizations. First, we want to provide training to all staff within the organizations on the policies and procedures governing HIPAA compliance. We want to define protective health information and access thereto by individuals, payers, and business associates. What should they be accessing for their role, and what should not happen during their role? Ensure that the training is based on the job responsibilities of the staff who handle the protected information. The only exception to training staff is if an organization is a group health plan that provides only benefits and does not create or receive any protected health information other than in the form of enrollment or disenrollment information. They are exempt from having to provide training to their staff. Ensure that a privacy officer is hired and designated, and then also that there's a contact person to handle questions or concerns regarding the protection of personal health information. And then lastly, the final rule adopting HIPAA standards for security was published in the Federal Register on February 20th, 2003. This final rule specifies a series of administrative, technical, and physical security procedures for covered entities to ensure the confidentiality of electronic protected health information. So again, we are all moving towards electronic, technical, and we need to ensure we have the security in place to still protect this health information, even electronic. Okay, to sum up our last section, each healthcare organization has a compliance program. Within the revenue cycle, staff need to understand the importance of compliance with federal and state program requirements. I'm going to be turning this over to my colleague Howard, and he will be reviewing the details of the Medicare rules on some of the upcoming slides. HIPAA requirements for privacy and security, as well as the opportunities presented through the electronic transaction sets, also impact our revenue cycle operations. So that is it for me. Thank you so much for your time today, and good luck on your exam.